Every year there's like, 7 or 8 middle school, high school football players that will get hit in the head and then collapse on the field and be taken to the hospital and will die or will be have a stroke from a single impact, right? You can work out your brain by staying active and doing puzzles and thinking and engaging in the world because that's how you keep making those connections. So you got to work your brain out to keep it sharp.
Ted, welcome to the World XP podcast. How are you today?
I'm great. I'm great. Thanks for having me.
Yeah, absolutely. You want to do a quick intro for the people, kind of who you are and what you do, and a little bit of what we'll be talking about today. And then, as always, for those listening who know the tradition, we'll get into the question from the last guest, and then we'll jump into the rest of it. But the
Right.
floor is yours. Tell the people who you are.
So my parents named me Theodore, but most people call me Ted. My last name Schwartz. And I'm a neurosurgeon. I'm a brain surgeon. So I specialize in mostly taking tumors out of people's brains and do it in a lot of different ways. But my career evolved to doing it in minimally invasive ways. So going up through the nose, making little incisions in the eyelid, the eyebrow, trying to making neurosurgery less invasive. I also do research in epilepsy and ran an epilepsy research lab for about 25 years, and most of my career was spent at Cornell in Manhattan. I'm a New York-based guy.
Very nice. So the question from the last guest is, if you had to revisit a time in your life when fear prevented you from going after what you wanted at that time, what lesson would you give your past self to help you get beyond the fear?
It's a really good question, and it's one that I think is great because everybody has an answer to a question like that. Um, I don't think a lot of my decisions were impacted by fear. I think my biggest fear was about going into neurosurgery and becoming a brain surgeon. I think I was terrified about that decision. And um, I ended up sort of taking a leap of faith that it was going to be a career that was going to fulfill me. And so it's not answering your question at all because it's almost the opposite. But I'm forever grateful that I didn't let fear interfere with that decision because what I see, and I have 4 kids, in them is this sense of wanting to be something, accomplish something, do something with their lives, and being worried that they won't have what it takes, and that they won't be able to rise to the occasion. Um, and I, and that the commitment to do it is going to be so overwhelming that they're going to have to give up so much of who they were before. And those were my fears, terrified of all of those things in choosing neurosurgery, because, you think of it as a overwhelming lifelong commitment where you sacrifice everything. And we can go into more detail about that. Um, but usually that's the time where you have to say, this is the thing I'm passionate about, and you go for it. And you just assume that it's going to work out. And you make the decision as if, and we could talk about the as if, which is sort of a philosophy of mine, as if everything's going to work out. Make those decisions as if everything's going to work out, and don't make them out of fear that it might not work out.
Mm, that's a good answer. That's a good answer. Even though it's not exactly the answer, I think the lesson is still there, which is like to
Yeah.
not let fear um kind of take over what you're doing. So for those listening, he's got a book. It's a great book. You should all get it and read it if you want to know anything about neurosurgery and the brain and everything else. There's lots of stuff that I had no clue about that I've learned. But I had a couple of questions that I wrote down for myself that I found very interesting before we get into, for those listening, kind of the normal flow of things. One is, you mentioned in the first part about a hemicraniectomy. Did I say that right?
Yeah, you did.
And you've got options for what to do with the bone. And one of the options is to stick it in the patient's abdomen. And I read that and I was like, how does that even work? And
Yeah.
so how does that work? And how, like,
So
yeah,
let's just, because we're here and we have some time, what is a hemicraniectomy? Why would you do it? Who
yeah,
did
yeah,
it?
yeah. Go
All
through
that
those
stuff.
as well.
So hemi means half, craniectomy means removing bone, cranial bone. And it's a surgery where you essentially open up a huge flap of skin and you take off half the skull. So you just remove it. And the question is, why would you do that? And so the reason you do a hemicraniectomy is that when you have trauma to your brain, severe trauma, the brain can swell. That's one of the things that happens. It's almost like if you bang your arm and get a bruise on your arm, your arm will swell. Or you get an egg on your forehead, it swells up. The brain will do the same thing. But the brain is encased in the skull. It's got a hard shell. So when it swells, it's got nowhere to go. And what happens is the pressure just builds up as the brain swells. And so you need to relieve that pressure or the patient will die. And so you have to basically pop the lid off the can, if you will. So we do this, it's often an emergency surgery when the brain is swelling after a trauma, where we go in and take off half the skull and open up the dura, which is the covering of the brain, and just let the brain swell. So you have to do something with the bone because eventually, when the swelling goes down, you want to reconstruct the skull. Otherwise, they're going to be missing half their skull. So one option is to put it in the abdomen to store it until they're ready to have it put back in. And you can put it back in 2 weeks later, or you can put it back in 6 months later. And so how that works is you make an incision in the abdomen, and underneath the skin, you can create a plane where you sort of elevate the skin off the muscles and the fascia and everything underneath it, and you can create a pocket under the skin and slip the bone in there and then sew it shut. So, for example, if you're this was done a lot in Afghanistan and some of the wars, combat surgeons who would save a soldier's life and then they'd be shipped back to Germany, wherever the main hospital was. They would want the bone to travel back with the patient. And the best way to have the bone travel back with the patient is to actually put the bone in the patient's abdomen so it travels with them and then it stays sterile, right? The reason you do that is the bone has to stay sterile. And by encasing it in the abdomen, not only does it stay sterile, but it gets a little bit of blood supply, it gets, nutrients and oxygen, and it stays healthy so that eventually when you need to put the bone back in, you can just retrieve it from the abdomen. Otherwise, you can either throw it out, that's an option, and then you have to reconstruct it using a 3D printer, and we can do that as well. Or you can put it in a bone bank. If you're at a big hospital, they have these freezers where they store bones for a while and you can then bring it back. But if you put it in a bone bank, sometimes it shrinks and it doesn't kind of stay that healthy.
So the follow-up to that is you mentioned like it can be in there for quite some time.
Yeah.
Is the person like if are you would a person be awake with half of their skull in there? Like how like I can imagine that's not very pleasant.
Yeah. Well, the part that's not pleasant is the fact that they had a head trauma and they're probably neurologically impaired for a period of time. And then they're going to rehabilitation and they're recovering. And their body's not working perfectly. And they also are missing half their skull. So that also does not look great. And so those patients have to wear a helmet everywhere they go because our skull serves a function. It protects our brain. If you're missing half your skull, you have to protect your brain. And the way they do that is with a helmet. And so the least of their worries is the bone in their abdomen.
That's fair enough.
Yeah.
Yeah, that makes sense. Um, then the other one that I got to or that kind of caught my eye was you tell a story in here about getting a vial of potassium chloride instead of, I believe, sodium chloride. If
Yeah.
and that I read that and well, I mean you can go into some of the background of that, but basically potassium chloride can be or is kind of lethal. And so you do tell some kind of the fixes and the procedures that happen later about
Yeah.
having
I
the
mean,
keys
the,
and the other things. But like walk me through that, but just because in the moment, like I can imagine afterwards the anxiety that you're feeling about like I mean, yeah, just walk us through the story and
so
kind of
yeah, the purpose of that story in the book is to introduce the reader, first of all, to what's on the line when you're taking care of a patient, what's on the line, and also when you're training and you're given certain responsibilities, how mistakes can happen, not because of negligence, but because you're trained. You don't know everything, right? That's what training is. And so it's also a story about why some mistakes happen. So in this particular story, I'm 4 months into my training, and I'm still an intern and I'm in sort of general surgery. You do general surgery first before you go into neurosurgery, and I did a 7 year training, right? So it's a long training after medical school, and I'm 4 months in, right? So I'm pretty green. And a code occurred on the floor. And you guys have seen, if you've seen TV shows, medical TV shows, when a code, like there's a patient who's becoming unresponsive, and a nurse recognizes it and calls a code, and a loudspeaker goes off on the floor, code room, 17, and everybody rushes in there to try to figure out what's going on and save that person's life. And I certainly was not running the code. I was a very junior person. The chief resident and the attendings, when they get there, are running the codes. So the chief resident was running the code at the time and sort of said to me, I want to give this medication. And when you push a medication in an IV, you give the medication and then you flush it in, right? Because you have to push the medication up through the IV line to get into the bloodstream. So usually you push that with sodium chloride because it's sort of an inert substance that's in all of our blood. And the resident said to me, "Oh, go get me a vial of sodium chloride." So I ran into the med room, and in the med room at the time, and this is again 30 years ago, there's a bunch of boxes, like literally when you get like something from Amazon or from the supermarket, there's like a cardboard box, and then there's a bunch of, imagine, soda cans, and it's covered with plastic wrap, right? So we had like 8 of those boxes lying around, half opened, like vials sort of everywhere, because 30 years ago, these med racks were not as well controlled as they are now. And I go in there, and there's a bunch of different half open boxes with the cellophane ripped, and I grab a vial and I run back in and I give it to the doctor who's running the code, and she draws up some of the fluid and pushes it in. And the patient, who's half awake, half asleep, is looking up and sort of still awake a bit and goes, "Oh my," and then just collapses forward. And it was right after the drug was administered. And I looked down at the vial, and on the vial in my hand, it said potassium chloride, KCl, and not NaCl. Not potassium, it just said KCl, not NaCl. Now, the vials for potassium chloride and sodium chloride 30 years ago were identical sized vials. One had a pink top and one had a green top. So there was a color coding. And then in writing, like small writing, it says potassium chloride or sodium chloride. And I didn't really know that the pink versus the green, I wasn't really, you flip it off when you get in there, so you can access the vial. And obviously, I was stressed out and running in and and trying to do this as quickly as I could. And I made the mistake and I grabbed the wrong vial, but they were sitting on the desk right next to each other, and they looked almost identical. To the untrained eye, they looked identical. And so at that moment, flashing forward, I looked down, I saw potassium chloride, and I thought, oh my God, I just killed this woman. I just gave her potassium chloride is one of the 3 drugs you give to a convicted criminal, or when you want to do assisted suicide, because it stops the heart instantly,
Hmm.
like that. And so I had this, I also tell the story because there's this moment of, well, what do you do? What would you do at that moment? On the one hand, there's this sort of question of liability, like what's my liability for doing this? Um, on the other hand, you have gone into medicine to save people, and here you've actually hurt someone. And on the third hand, you want to do everything you can to help the situation. So what I did was, of course, I ran over to the chief resident and I said, I gave you potassium chloride. And she literally pulled me aside and she said, do not tell anyone what you just told me. And she went back and saved this woman's life because she knew what the problem was and she knew how to fix it. So I was luckily off the hook in terms of, liability and also my incredibly guilty conscience, as you can imagine. Um, and that taught me so many lessons, one about double and triple checking everything and how important that is in medicine, when so much is on the line, you can't just make careless errors. Um, and uh, it's a lesson I'll never forget. And it also teaches us about our own fallibility and my own fallibility and how you have to be constantly on yourself to better yourself, and humility and how important it is to be humble, as a doctor. Um, and subsequently, those vials are now like in a locked cabinet and completely separated, And when I did research for the book, I remembered this story from 30 years ago, and I went online to figure out how often this happens. And there was I found in the UK there was it was reported as one of the most common accidents that would happen in hospitals, where they would give potassium chloride instead of sodium chloride, and they realized that they had to separate them and they couldn't put them together. And it was also a systemic error, like within the hospital system. Like I was a little bit set up to make that mistake, right? They had made it very easy for me to make that mistake. And now hospital systems know that. And so they separate them and put them behind, the potassium chloride. You need a key to get it out. It's not just sitting out on a counter, a deadly medication. So there's a lot of little lessons in that story. And the book is obviously filled with stories like that I learned from, that people may not be aware of, and where I try to sort of weave it in with the significance of, what neurosurgery is all about.
So what happened? Like she tells you that, and you're kind of a little bit like relieved a little bit. And then what? Does she run back in? Like how does that I guess is there like a procedure or like a and like another medicine that counteracts it or
Yeah, she knew what to do to fix the problem, and at the time I didn't know. I barely knew my way around the hospital, let alone knew, what medications to give to fix injections like that.
how quickly, I guess, how quickly were you in like or like how long were you in kind of suspense of the outcome? Was it was it
It,
is it more of an immediate thing for that like because she knew so early and
It was maybe a minute. Look, if it was probably a minute and it felt like 10 minutes. And
yeah,
it was also 30 years ago. So, do I remember every detail afterwards of,
yeah.
second by second how I felt? But obviously it was a powerful enough memory that 30 years later, when most of my sleep deprived residency was a blur, that memory is pretty vivid in my mind.
Yeah, that makes sense. And to go off that about the hospital system kind of almost setting you up to make that mistake. I think we've seen, at least in the last 5 years, there's been a loss of trust in institutions, specifically in the medical kind of, whether it's pharmaceuticals or these other kind of medical institutions. And stories like that, not that that's what you were doing, but they lend themselves kind of to people that already are maybe inclined to think of that way. Do you have thoughts on that sort of thing? Like there will be scenarios about kind of primary care doctors that don't really know nutrition and that rubs people the wrong way or like whatever the case may be. Like
Yeah.
there's tons of instances that I don't need to go list them all.
Yeah.
But like
Yeah.
what are your thoughts on that kind of situation? Because to me it's a little bit concerning just from the perspective of like some of it I think is probably the loss of trust is probably rightly so, but at the same time there needs to be some sort of trust in an institution like that to be like, yeah, this is the place to go if I need to get healed and all these other things. So I like how have you dealt with that? Does it come into your hospital and your workplace on a more frequent basis? Like what do your colleagues think? What do you think about it? Like where do you think is there a way to get it back? Like what are your thoughts on that on the whole kind of situation that we're in?
Yeah. So I have a lot of thoughts on it, and it's a great question, and I'm glad you raised it. For example, that's a scenario where the institution, you know, maybe wasn't doing everything perfectly. However, if you fast forward, they then enough people realized that that was a problem that it was eventually fixed, right? So you could say the event itself would engender a lack of trust. Um, and but you should also then say, well, this was remedied. And I think that one thing that people don't appreciate about medicine, and it's also true about science, is that we are making decisions based on the best available evidence at that moment in time. And sometimes we're wrong. But we're not wrong because we don't care, and we're not wrong because we're trying to deceive you. We're wrong because the answer is not known. Like science is imperfect and it's evolving constantly over time. And I talk in the book a lot about how a lot of our treatments evolve over time and how we
Hmm.
used to do it and how we then did it and how we do it now. And then there's how we're going to do it. And so I think people want medicine to be perfect. They want to go into a hospital. They want to know, should I get a COVID vaccine? Yes or not? Yes or no? Does a mask work? Yes or no? All of these answers definitively. And they don't realize that at that moment in time, sorry if my phone is ringing. At
It's
that
okay.
moment in time, and I don't want to get into the politics of COVID, et cetera, it's just too political.
Hmm.
Um, but to some extent, there were many people who were making the best decision they could with the evidence that they had at that moment in time with a new disease that they knew nothing about, that they didn't really know how well it spread, and they didn't know how deadly it was going to be. And they also had to say, let's take the worst case scenario that this thing is going to just wipe out half the population. How are we going to prevent that? Because we have to prevent the worst case scenario, even if our restrictions in the short run might be more than they needed to be, right? And they probably were more than they needed to be. And the economy was probably shut down more than it needed to be shut down. But is that because the people in charge were dumb, or because they wanted to prevent a disaster and they weren't sure yet that we weren't facing an enormous disaster? And so the restrictions were a little more extreme because they were still figuring out what this disease was and how it worked and how quickly it spread and what the best prophylactic measures were. Did it then become politicized and people made bad decisions? Absolutely. And that leads to a lack of trust when medicine becomes really politicized and it's one side versus the other. Um, so I think that most doctors, it's certainly in neurosurgery, go into medicine. The doctors, because you also have to separate the doctor from the institution,
Yeah,
right?
because I
In
was I was
Caligars, the
gonna go
doc,
there. I was gonna
yeah,
go there as well because lots of people have issues with the insurance and all the other things that go
correct.
along with it, and those are not the same as
As
like
the
you mentioned.
caregivers,
Yeah.
right? So, most 98% of doctors, they become doctors because they really want to help people, right? Like we want to be there for you. We want to help people. Institutions have to want to deliver care, but they have other priorities. They have priorities that have to do with, meeting certain metrics that are meted out by the government. Insurance companies have to make money. Hospitals have to make money so they don't close their doors. And so that will shift their priorities slightly, so that it's not always about the doctor and the patient and making that relationship, as perfect as it can be, because institutions have different priorities, unfortunately. But I think for the most part, the doctors and the researchers really have the patient's best interest at heart. Like they're, in many cases, sacrificing their lives and going into this profession to try to take care of other people because they really want to make people better. Like they're good people who want to help. So I have a lot of sympathy for doctors. It upsets me when the public loses faith in the medical profession. I can understand losing faith in insurance companies. I detest insurance companies from a provider standpoint. I mean, it's horrible. You're having to call them and talk to a pediatrician on the phone to get a brain surgery approved. When they say no, we not giving you permission to take out a brain tumor, and you have to speak to a specialist in the insurance company, and you're talking to a psychiatrist or a pediatrician who doesn't know anything about brain surgery, and they're telling you what you can do. I mean, those kinds of things are incredibly frustrating, and the finances of the insurance company are incredibly frustrating. And the same is true of, working at a big institution like a hospital can be very frustrating. There's an enormous amount of politics and red tape and bureaucracy. So that's very frustrating, for us caregivers as well, and it impairs our ability sometimes to even be the best caregivers that we can be because you're expected to see X number of patients in X number of time and document things in a very specific way. And there's an enormous sort of bureaucratic burden placed on caregivers just working within the healthcare system that is weighing on us when we see our patients.
I've heard that a lot, not just from you, but other kind of doctors I've talked to on the show, or just like sometimes if I'm in the doctor's office and he's got a second or whatever, and because I'm a curious person, so I ask these sorts of questions, and across the board, I get that exact, basically that some version of what you said, and it seems if it's so widespread that sentiment, then there should be steps to kind of mitigate some of those things, right? To some extent, I get why there's documentation that needs to exist and all these other things. But at the same time, like And also, it's probably different for each kind of genre of doctor. Like for a neurosurgeon, is different than a primary care, and like what goes on and those sorts of things. But I just I don't know. I don't have my finger on the pulse of what's going on in the medical industry from that perspective. But is there a push kind of from the doctors and the caregivers to be like, hey guys, this is too much. Like people are frustrated. We don't have good relationships with our patients because they're spending all their time doing paperwork instead of actually like I've had this problem with like when you call the insurance company and then you have to prove that something is medically necessary is the most
Yeah.
infuriating thing in the world because it's like, okay, well, I guess technically I won't die, but like I would like this to get fixed, please. And I mean, are there steps or is there kind of some sort of, I don't know if movement is the right word, but like,
Yeah, I mean, physician burnout is a problem, and part of the reason there's burnout is because of dealing with all those problems that we have to deal with, and hospitals do try to put some uh, certainly lip service into trying to remedy physician burnout. But has there been meaningful change? No, there hasn't. And the physicians want to take care of patients. Like that's the thing. Like our focus is more on patient care because that's what we want to do. But it what it does is it undermines our ability to have the time to speak out for ourselves, and speak out against certain policies that can be infuriating in insurance companies. And we're just sort of powerless in the middle, to a large degree between, the hospitals and insurance companies really have most of the power and most of the money, and the patients obviously are the product that we all want to take care of. And the doctors are kind of caught in the middle because we have these two powerful industries above us without which we cannot practice medicine, and so we're beholden to them. And we're beholden to our patients because that's really what we want to serve.
yeah,
Can't just serve them without also serving these monolithic industry, medical industrial
yeah,
complex.
yeah. No, that I mean, yeah, that makes total sense. And even I had a woman who she started off as a nurse and she ended up as the chief operating officer of a big hospital system out in California. And she felt the same way the whole way up through even as the chief operating officer. She was like, this is ridiculous. Like, anyways, we don't need to spend so much more so much more time on that. I did want to touch on so in the book you talk about the training part, and there's not really a way to do training wheels with brains. Like you kind of just the first time you do it is the first time you do it for a lot of these responsibilities. Um, talk through the kind of first I don't know, 6 months or whatever of you being on the job, like how they get you ramped up to actually start working on um like live patient yeah, I guess live patients is I don't know if there's another term for that, but like how you start to get ramped up on actually using the tools that are available and in practice in real situations versus like how does that work? Because other situations there's like dummies or like with if you're training to be a barber or whatever you get like the fake person with the wigs and you practice and you don't have to butcher somebody's haircut the first time you
Yeah.
do it. So how do they kind of get you acclimated and ramped up into that?
Yeah, there are not great simulators for neurosurgery. There are some that exist, and we do have that sort of training that we do at national meetings, and we'll have like an intern, retreat where, young faculty, not faculty, but in training residents can go and get a little bit of that type of training. But ultimately, as you can imagine, you don't really learn it unless you're doing it. So, how do you train someone to do brain surgery? And the answer is that it's a graded responsibility where initially there are simple aspects to surgery, right? Because you imagine the first thing you have to do is cut the skin, right? So, you imagine it's not that challenging to teach someone how to cut along the line, right? So you're first just having them, let's cut along the line. And then there's some bleeding. So we have to stop bleeding. So how do we stop bleeding? And you're teaching them how to hold a suction in one hand and a bipolar, which is like a tweezer with a electrical impulse that goes between the tips, a cautery. So how do you hold that? How do you find the bleeder, cauterize the bleeder? Just open up the flap. And sometimes as a resident in your first case, you may just do that. You may just make an incision or part of an incision and do a little cautery, and then you're just kind of assisting for the rest of the operation. And then in the next you might do that for a month, and then the next operation, now you're drilling holes in the skull. So you have to learn how to drill a hole in the skull. Now, the old days, when I learned how to drill a hole in the skull, you actually used a handhold crank called a Hudson brace, where you would push down on it and basically turn it with your hand. It was a manual drill to drill a burr hole. And that was done until, the 1980s, 1990s, before we got electric drills. Now we have these high-powered, either electric-powered or air-powered drills that spin, 10,000 RPM, where we can just kind of shave away the bone with our hand. So you teach them how to do that. Where do you put the burr holes? How do you connect the burr holes to do what's called a craniotomy to elevate the bone? Right? And that can be a period of, months, just sort of learning how to do a craniotomy. And even there's like little tricks. Like when the bone bleeds, we use wax actually to stop the bleeding in bone. It's literally a piece of wax because when blood comes out of a bone, the center of the bone of the skull, you can't cauterize it, right? So you just sort of put some wax on it. And then you have to actually tack up the dura, the covering of the brain. You can't just open it right away. We actually put sutures and attach the dura to the bone because we're trying to prevent blood from accumulating between the bone and the covering of the brain. So it can take, months to sort of learn how to do that. But as they're learning this, they're basically learning how to use your hands, right? You're learning how do you get your hands to do what you want them to do? And then there's, of course, tying knots, right? We tie knot after knot after knot after knot. We're constantly suturing and tying, suturing and tying. So they're manual skills, just like learning how to hit a baseball or learning how to hit a golf ball. You just do it again and again and again, and you train your body to do it so many times that eventually you're not really even thinking about it. And just like all great athletes, they don't become great until they take their brains out of the equation, and it's just sort of natural. They're just being athletic because they've done it so many times. So you have to do surgery so many times that it just becomes natural, and the instruments become an extension of your hands. And then over time, now you've been in it for 3, 4, 5 years, you start to work on the brain a little bit as an assistant, and and you're always there with someone else, right? There's someone else looking over your shoulder who's helping you, and God forbid there's a little bit of a problem, they can fix it, and they're only letting you do what they think you can do, and you're doing it together. Um, but it's very scary. And as you go on, there are some things. This is really the most um, scary part of it is that there's some maneuvers that we do in brain surgery where if you get it wrong, there's no fixing it. And even if you can fix it, sometimes you've caused permanent damage because you got it wrong. How do you train someone? How do you let someone do that? How do you teach someone to do that when another human being's life and their future is on the line? And that relationship is very challenging because here you have a trainee who's dying to learn how to do this because they know that they're going to have to be out in the world doing it on their own at some point. You have the full professor who the patient has come to and expects a perfect outcome from. They have a responsibility to the patient to make sure everything is perfect for the patient, but they also have a responsibility to the trainee to teach them how to do this. And they also have a responsibility to society to teach the trainee how to do it. Because the minute the trainee leaves their residency program, they're going out in the world and they're operating on their own, on people, right? And if you haven't trained them to do it well, they're going to hurt people because you did not train them to do the job appropriately. And you could be their patient someday, right? So you want to make sure they're well trained for that reason as well. So it's a very difficult responsibility and position that a training neurosurgeon has in training someone to do neurosurgery because you have conflicting loyalties to the patient, to the trainee, to society, but my sense is that your first and foremost responsibility is to the patient, right? Always. Always, and that's one of the themes of the book, right? It's like so always put the patient first, and then everything else will sort itself out. And that's how I've lived my career. I want to make sure my patient outcome is perfect as best I can, even if the trainee is upset at me because I didn't let them do enough or whatever, it took too long or whatever negative consequence could be for putting the patient first. There's another case following, and my case went over like 3 hours, and so the next surgeon's mad at me because it took too long to get my surgery done. But I have to live with myself and the outcome of the patient. That's the first priority, and you can't live with yourself unless you feel like you did absolutely your best job and the outcome was as perfect as it could be. So it's a lot of talk about how to train, but it's a challenging thing to do. But luckily, the majority of neurosurgeons come through training very well trained because their professors are really good at training them, and we know how to train them over time. And it's a process. It's a 7-year training program. I mean, that's a long after 4 years of med school, right? So I remember writing in the book when I finished my training, I was 33 years old, right? I finished my training at 33. Imagine that, right? That's a long time to spend learning how to do something before you get to do it.
Yeah. It's interesting you mentioned the athlete thing because that was my gonna be my next question, which is at a certain point as an athlete, you're going on autopilot. But sometimes you make a mistake and then you're in your own head. And so not to harp on the story that we talked about before, but when something like that happens, how do you get out of that in a way that, because you've got to get out of it quickly, because you can't spend the
Yeah.
next three surgeries second guessing yourself the whole time, especially if, right, you mentioned about these cases where if they had been seen like even hours earlier, maybe they would have lived or a different outcome would have happened. And so time is often of the essence in the scenarios that you're working in. So how do you kind of sort through that and like in athlete we call it goldfish brain. It's like you forget the mistake and you move on immediately. Like how do
Yeah.
you do that for a scenario where the stakes are what they are as you
There's
mentioned before?
there's two aspects to that I would want to separate out. One is in the moment of crisis, like suddenly there's a huge amount of bleeding that you have to fix. You either are you're in the problem fixing it. Sometimes you become meta. In other words, you think about yourself fixing it, and then it's when you get nervous and scared, and you say to yourself, "Oh my God, if I don't fix this problem, this patient's going to die." And if you start thinking that way, where you're not thinking about fixing the problem, you're thinking about the consequence of not fixing the problem, that's you're going down, you're spiraling in the wrong direction. Right? It's almost like when you're up at bat and you're thinking, "Oh my God, if I strike out right now, I'm not going to get my contract next year," or something like that, right? That's
Yeah.
not a good swing thought for the for the batter. You need to be thinking about, where the ball is and how, or not thinking. So one important thing is not to think about the situation and the consequences, but just to be 100% focused and present in the moment and reacting, physically to what's going on. And that's the first challenge. The second challenge is the one that you described, which is how do you recover after a mistake has happened or a problem has happened? And that's very difficult. And so, what surgeons have to learn how to do is to compartmentalize, right? Because we could have a case in the morning, and there could be a problem in that case, and then we have to go back in the afternoon and do another case, right? And you have to be 100% and focused and present in the moment. And so you develop a little bit of what's called emotional armor, where you kind of erect this armor and you wall it off and you move on, like having a goldfish brain to some extent. But the problem with having that too much is that we have to learn from our mistakes. Like it's
Yeah.
incredibly important to learn from your mistakes. So you then have to go back and revisit and say, all right, what did I do wrong? What could I have done better? What can I do to make sure this never happens again? And then you have to live in your mistake. You can't just block it off and forget about it. It's like going to the film. It's like, when after the game,
Always,
you go
yeah.
in the room and you watch the film and you go, all right, now let's talk about the mistakes that you made, right? Because we got to review them and figure out why this block was missed, by the tackle. So, but at the moment, you can't be thinking about that, right? And so you have to have emotional flexibility. You also have to be, you can erect emotional armor, but you can't live that way as a human being because you also have to be a sensitive doctor and you have to have compassion and warmth. And so you have to be able to erect emotional armor and then bring it down and be emotionally flexible. And that's the challenge of being a great physician and a great doctor, and a great surgeon is to be in and out of that and be able to control your emotions. And then you come home to the dinner table, right? And like your kids are there and you have to then become a different human being as we all do. We take care of our children.
Well, that's exactly why I ask because to your point about goldfish brain, it's in the moment in the game, goldfish brain, then you go revisit and learn from what you did afterwards in the film exactly like you mentioned. But the reason why I really wanted to ask, especially about staying present in the moment, is because I think a lot of people struggle with that, and kind of what you're doing is at the most extreme end of kind of all of those different aspects that you mentioned of being able to compartmentalize, have the emotional armor, then you go into like after you're done with surgery, then you go see the patient's family and you have to be warm and like and compassionate and all those things that you mentioned. Do you, is that something that is cognizant within the training of like, hey, make sure that you speak this way and make sure that you're able to wall that part off and you have to have thick skin? Like, is that part of the training, or is that something that you had to develop on your own and kind of, I would, if you could answer in a way that can other people can apply to their own kind of whatever it is that they're doing in their life, like some of the tips that you use or tricks that you use to be able to do that successfully.
So it is not part of our training at all. You are just expected to be that way. And it's
Interesting.
unfortunate. And that's one of the reasons I wrote about it. There are not a lot of books written by neurosurgeons about neurosurgery. There's literally a handful of them. And we're not expected to open up and talk about our feelings, and what is it like? That question of what is it like, and that's what motivated me to write this book. I come from a slightly different background than many neurosurgeons, not all, and so I felt like I could bring that into my writing, to sort of dig down deep a little bit and ask some of those questions and try to answer them honestly and thoughtfully. Um, but it's sort of like necessity is the mother of invention to some extent. I mean, it's almost like teaching a baby to swim by throwing him in the pool. That's a little bit of what brain surgery is like to some extent because there's just so much that's thrown at you at once. Um, it is a graded responsibility for sure. You're not like doing complex operations in your first couple of years. You're more taking care of patients on the floor. Like that's your job is to take care of patients on the floor before and after surgery. So you kind of learn those skills and you're talking to patients much more and not in the OR as much. That's in the latter half of your training, where you're talking to sorry, excuse me, where you're operating more. But it's really not dealt with. It's not taught. It's something you pick up. You're
Mm.
forced to pick up.
On the point of graded responsibility, once you finish your training and your, I guess, chief resident, is that the right
So
term?
last year is your chief residency, yeah.
Or so like once you're like done with, you're off and you're a full-fledged surgeon and you're kind of off and doing your own, well, not own thing, but you know what I mean. Do you run into situations where a patient will come in with something that you've never seen before? And then how does that work? Like just
Yeah.
from like how do you figure it out and like or do you have like other colleagues or mentors on speed dial that you're like, "Hey man, this just popped up. Did you ever deal with this?" And how does that work?
So everyone handles it differently. I would say the way that I handle it and many doctors do, the answer is yes. Like we all have colleagues, and we know people in our field that have seen certain things more than we have. And you make a decision whether you're the best person to handle this or someone else might be. And so we will send films to each other and ask them, what do you think? But that's not common. Most neurosurgeons feel like they have to be able to handle everything. There's a sense of pride in it. And sometimes we get in over our head by tackling things that we shouldn't tackle because maybe we watched it done once or twice as a resident and we say, oh, now I should be able to do this. And you try to do it, and either you're successful or not. And if you're successful, you have confidence and you keep doing it. And if you are not successful, you may start referring it to somebody else. But one of the things I talk about in the book that's not well understood by the public is that not all neurosurgeons are created equal. And there are some neurosurgeons that specialize in certain things, and there are others that are more generalists. And um, if you don't get your hands in the ones who specialize in something, particularly if the thing you have is not that common, your outcome is not guaranteed to be as good as if you were in the hands of that handful of neurosurgeons who specialize in those things. And it's very hard for patients to figure out, first of all, how uncommon is the problem I have? How well equipped is the surgeon that I'm seeing to handle this problem? Because they're going to we learn to express confidence often when we see our patients. Like no one wants to see a neurosurgeon who's not confident. And if you're not confident,
That
your
wouldn't be good.
practice is going to dwindle pretty quickly, right? So you have to figure out how do I exude confidence, but not be arrogant. right? And how do I exude confidence, but make sure that I'm taking care of the patients? And how do I know if I'm not the best neurosurgeon to do this operation, I should be sending it to a colleague? There are definitely patients that I have sent to colleagues where I say, I am not, and I'll say to them, I know you're coming to see me because you heard I was a good neurosurgeon, whatever, but this is not really what I do most of the time. And I'm going to refer you to someone else who does this more than I do because you'll have a better outcome in their hands. Um, and and consequently, the same happens in reverse, right? Because then you become an expert in certain things, and then people will say, you know what, Ted Schwartz is really good at this. Why don't you see him? I'd be good if it were this, that, or the other. So that requires the humility that we talked about. And so you have to balance the confidence with the humility in order to, and it's a very fine line, but in order to be successful, in order to give the confidence to your patients and to feel confident in yourself, but also know when you're in over your head and when you should be sending something to someone else. But the other problem is like, how do you learn how to do it? So when you're starting out in your first couple of years, the truth is there is always someone who could do it better than you.
Hmm.
But then if you send every case to someone else, you'll never learn how to do it. And that will not be good for society.
Yeah.
So you have to say, all right, I'm going to be good enough. My results will be good enough that I need to do this. And I need to do this case because I need to learn how to do it, as well as I can so that I can help the next 40 patients who come to me, right? Because I have a responsibility to the next patient to come to me to be better. So I have to do it now. And it's scary to think about as a patient that your surgeon might have a learning curve. And you could
Is
be
that on a case by case basis? Like
absolutely case
some
by
days you're
case.
kind of like, oh, I don't know about this one, but then maybe if you got the same one 2 months later, you'd be like, no, I'm gonna do it.
Yes, absolutely.
Interesting.
And the other thing, and I read a little about this, is like the decisions we make are sometimes impacted by the outcomes that we had last week. So like if I'm doing a certain operation and it goes great, 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 and then the next one doesn't go so great, and then I see another patient, I'm thinking about the one I just did. And I may say, you know what, maybe we'll radiate this one. We're not going to do surgery on you. Like I changed my mind. Um, and if I had seen them the week before, I would have offered them surgery. So neurosurgeons are subject to the same um, sort of external forces that lead us to make decisions. I don't know if you ever read like Dan Kahneman and all this behavioral economics about, he writes about how we make decisions and how there's so much bias in the decisions that we make and how recent events are more likely to impact the decisions than events that happened a long time ago and what leads to those bias. Like there are all these, he writes these stories about judges who, like right before lunch, um, will say that more people are guilty because they want to get them out of court and go to
Yeah.
lunch quicker. But they're not even aware of it. Like it's unconscious bias. It's unconscious bias, because it's right before lunchtime. So you're more likely to be guilty because they're thinking about their lunch. So everybody is subject to that. And we have to actively fight against that. And I don't know if you seem like you were an athlete. What was your sport?
Soccer.
Oh, it was soccer. Um, it could be like penalty kicking. Like you kick the penalty. If you did a bad job on it a couple times, it may change the decision you make the next time you kick that penalty kick.
Yeah.
And the one that just happened most recently is going to most influence whether you're going to go right or left or whatever the decisions you make when you're kicking a penalty kick. I'm not an expert in soccer, so I'm kind of making this up,
No, no, no. You're
but
absolutely right. Absolutely right.
you get what I'm saying. But it's scary to think that your neurosurgeon is subject to those same sort of whimsical influences. Now, I don't want to get people nervous because, like, you have to understand, like, our outcomes are 99% great. And
Hmm.
neurosurgeons train their whole life to get the best outcomes that we possibly can. And we're really good at what we do. And our outcomes are almost universally great. So, but it's sort of like remember you talked about losing faith in
Hmm.
doctors, we're still human beings, right? And so we're not going to be perfect every time. We can't be. We try to be perfect every time. I mean, I am so regimented. I'm going to bed at, 10 o'clock every night, not drinking, waking up the same time every morning, eat the same meals every day because you want to get your body just like a well-oiled machine, so that you're functioning at your best every time. And so we take that very, very seriously.
Yeah. I think also for deep down, people all realize or remember that doctors are humans, and if they kind of were to think about it for 2 seconds, I think a little bit more grace could be afforded in some scenarios, definitely. I would, however, I was interested in did you watch the concussion documentary that came out from the NFL? I don't maybe 7 years ago, something like that. So you talk about the concussions in the NFL in the book about them kind of saying, well, okay, it's not actually a concussion problem and or this or that. Can you talk through for people listening kind of what a concussion really is? And you also mentioned the second impact syndrome with a couple of high school football players. And so there's been a push with youth soccer that kids under the age of like 13 aren't allowed to head the ball yet. And then like that's good, but then also when they start to be able to head the ball, nobody's taught them how to protect themselves in the air, and that's not great either. Um, but just the sports side of head injuries and kind of what I don't know what it's a very open-ended kind of question, but
Yeah.
there's a lot of
There-
sports people that listen, so not be
Sure.
doing my job if I didn't ask the
No, no,
question.
no. It's a great question. There's two ways to think about head trauma in sports, and um, one is the possibility of a devastating out problem from a single impact, right? And this happens every year. There's like, 7 or 8 middle school, high school football players that will get hit in the head and then collapse on the field and be taken to the hospital and will die or will be have a stroke from a single impact, right? And that's this thing called second impact syndrome. It really is not the same as concussion. It's very different than concussion. People think of it as similar. It's head trauma during sports, and do I need to let should my child go to sleep at night? Are they going to die, in their sleep after they've hit their head? Um, Second impact syndrome is a phenomena that occurs, and it was described by a neurosurgeon, Richard Schneider years ago, where there's a first blow to the head, and then this was the original thought, and then there's a second blow within a short window. And because of that short window between the first and the second hit, the brain swells of a child, and it can be devastating and can, lead to death. Um, and what we've learned over time is that it really doesn't have to be a second impact. It could be a single impact. And you can have second impacts that don't do anything, and it's really like the third, the fourth, or the fifth impact. But there's something unique about the brain of a teenager and a middle schooler, teenager, that with the right kind of impact can lead to a disruption in the regulation of blood flow to the brain. So it just kind of starts swelling up out of control. It's very rare for that to happen. And if it happens, it usually happens right away. It doesn't happen, 7 hours later or 10 hours later. It's like immediately on the field. And we don't really know how to identify it or prevent it, unfortunately, but it's a very rare case for that to happen. Now, concussion is separate because what's really scary about concussion is not as much the fact that a kid gets hit in the head and then sort of has a headache and doesn't feel well for a week and can't go back to school and can't focus. That is a concussion. And you should not play sports until you've gone through the protocol, where you're feeling better and you go to practice and then you have no light doesn't bother your eyes, and then you sort of graded return to sports, and then eventually you can play again when it's all gone. Obviously, if you have a kid who's had multiple concussions, they probably shouldn't play anymore. Like after 2 or 3 of those kinds of concussions, they're sort of telling you this is probably not great for them and you shouldn't do it. But the heading thing is different. And what we worry about long term in the NFL is this CTE, chronic
Hmm.
traumatic encephalopathy. So the story there is what we've figured out is what's the most important thing is repetitive subconcussive injury. So you don't have a concussion, but you bang your head, you bang your head, you bang your head, you head the ball, you're on the line, you get hit by the linebacker, you're tackling, you're blocking, head, again, again. No concussion, no headache, just keeps happening. You do it for you're in third grade a bunch of the times you hit your head, fourth grade, fifth grade, sixth grade, seventh grade. You're in college hitting your head. So those build up over time, and that's what leads to chronic traumatic encephalopathy and long-term brain damage from proteins building up in the brain. So that's why they say you shouldn't head the ball when you're young because it's the amount of years, consecutive years that you've had head blows that don't have to lead
Mm.
to concussions. You just have to hit your head enough for enough years. And it's like probably like 8 or 9 years. And that's why when you start really young, um, that window, you could just be in high school and have been getting head trauma for 8 years if you start young enough, right? If you start in second grade and you're getting hit in the head till you're a senior in high school, that's probably enough to cause long-term brain damage, right? So that's why they say don't hit when you're younger, and then you start hitting when you're in whatever, in eighth grade, ninth grade.
Yeah.
You have to, and then hopefully you're done. At the end of high school, you're done. Now, if you go on and want to be a college football player and a professional athlete, then you're putting yourself at long-term risk, but you also might get paid a lot of money to do it. And so then you say, well, maybe the risk reward is worth it. And the other issue is like, so obviously there's some people who can get hit a million times in the head and have no problem, right? You look at like Peyton Manning, he's sharp at his attack, and I promise
Mm,
you, he's gotten hit in the head a ton.
yeah.
Then you look at some other football players, and they're a mess. So there's obviously a genetic predisposition in some people who have repetitive head trauma who will get cognitive issues and CTE, and there are others who won't. And we don't know who that is. We don't know how to make the diagnosis while someone's alive of CTE. They actually have to die, and we take the brain out of their head and look at it. You can't make the diagnosis without that. Um, so that's kind of my quick take. I don't know if that raised other questions for
I don't
you.
know. How much do you have some more time?
A little bit more time. Yeah, I
Okay.
can do like 10 more minutes. How's
Okay,
that?
perfect, perfect. Um, yeah, it does a little bit, but I think, I mean, it feels like a lot of the answers that we as a society or science don't really know, and we're still kind of looking for answers. So, in the interest of, I guess, I'll pivot to this slightly. Um, and I probably should have done this at the beginning, but if you want to talk about the different types of oh, actually, you know what? There is one. This is related. You mentioned like after 25, the brain starts to atrophy, and I was wondering about that and kind of what you meant by that because it also you hear that oh, your frontal lobe's not fully developed until you're 25, and then I was like, okay, but also as soon as it hits that, it starts to atrophy. That doesn't sound that doesn't sound great. So if you want to address that, and then also kind of the different parts of the brain, and that's the thing that we should have done at the beginning, but I was interested in the other stuff. But anyway, so those two kind of things.
Yeah, I mean, look, so the brain is one homogeneous organ, but we divide it into lobes somewhat arbitrarily: frontal lobe, parietal lobe, occipital lobe, temporal lobe. And each part of the brain has different functions, but it's not like there's also parts of the brain that have multiple functions, right? But we do know that there's a part of the brain that moves the left arm, the right motor area, the right frontal area, and there are parts of the brain. So for motor, there's a part of the brain that processes vision. All of your primary senses will go to one specific part of the brain that will process that information. Um, but then there's huge parts of the brain that are sort of multi-sensory integration, where they're sort of putting stuff together, association cortex, where you're figuring your thoughts are coming in, you're figuring out how to speak, they're doing all these calculations. Um, so when you're looking at the brain, you can't see, there's no line in the brain that says this is the frontal lobe. This just like when you cross the border from, Canada to the US, there's not a line in the ground that says like you're here. It's just a random arbitrary line that we have decided. And it can move. So those are the lobes. There's also the cerebellum, which is in the back of the brain. There's, the brain stem, which is in the middle that gets to the top of the spinal cord. I mean, there's a brain anatomy is pretty complicated, and there's a lot of little modules, and each one of them has its own name and its own connections. And med students, find neuroanatomy some of the most daunting anatomy to learn because it's so complicated and there's so many pathways, and they have all these crazy names because they were named by anatomists who died 200 years ago, and you have
Yeah.
to learn them all for the tests, which is funny. um, so that's brain anatomy, and then you had another question.
The brain. I think you had a
Oh yeah,
sentence in the book
right.
about yeah, yeah.
So what happens, it's not that your frontal lobe is not developed. What happens is there's a process of what's called myelination. So the neurons are there. You're actually born with a lot of neurons. There's not that much generation. There's some regeneration of neurons, but most of them are there. And the covering of the neurons in the brain have this fatty substance called myelin, and that takes time to develop. And that allows the brain to process information better, faster. And so that's a process that goes on for a while. But what happens is over time, you do start to lose neurons. Your neurons will die off. But your computing power of the brain is not a process of the absolute number of neurons. What's more important are the connections, how the neurons talk to each other, how effectively they talk to each other, and in what patterns they talk to each other. And those connections go on throughout your entire life. You're constantly making new connections. Think about it. Every time you have a new experience and you have a new memory of that experience, there's a new connection that's formed in your brain so you can remember that experience as you have that experience. So um, don't feel so bad because it's not all, size doesn't matter. The quantity of neurons is not the only thing that's important. It's their connections, and you can keep making connections when you learn. That's why staying active, it's like doing push-ups for your bicep, whatever, your pecs. You can work out your brain by staying active and doing puzzles and thinking and engaging in the world because that's how you keep making those connections. So you got to work your brain out to keep it sharp.
Yeah, that makes sense. I will pose this thought to you, and if we don't have enough time to dive into it, then that's okay. But in terms of, you mentioned the brain staying active, of course, we've got diseases like Alzheimer's and Parkinson's and all these other kind of neurological diseases. And also kind of, I guess, related, but there's also seemed to be this outbreaking of kind of the nootropics. People are taking things, they say, oh, this helps with your brain function and this staves off Alzheimer's or things of that nature. Do you have, for like people listening, like how should they be thinking about that sort of thing, just generally,
I
in
would be
terms
very
of,
skeptical when someone tells you you can take a pill and it's going to keep your brain functioning better. Unless that has been proven in a what's called a randomized controlled clinical study. Like this is how science progresses forward, where you take two populations, you give half of them a drug, the other half get a sugar pill or a placebo, and you test them very specifically before and after, and you see which population has a specific change. So just a lot of the stuff that you see on TV, commercials for on TV or neurotropics or things like that are not really regulated by the FDA. So they can make certain claims because they're not medications, they're supplements. You can claim a supplement does almost anything.
yeah,
You can get away with it, and it can be vaguely based on some animal study, that maybe was, but never done in humans, or never a trial that was appropriately done, where and reproduced. Like, if one study shows something, we know most doctors will say, well, has that been reproduced in another study? Like, has another lab shown that? And if you can't reproduce it again, it could be worthless. You have to be very skeptical. And that's what leads the public to not trust doctors, right? Because like one week aspirin's good for you, and the next week aspirin's bad for you, and the next week wine is good for you, and the next week wine is bad for you, alcohol is good for you, it's bad for you. Like if you get that information, you're like, I don't trust anybody. Like you told me, the medical community told me a year ago that I should be taking aspirin and drinking a glass of red wine a day, and now I don't take aspirin, I don't drink any alcohol. Like what happened? You did those were good studies. You did this Framingham study, but the point is that we know that medicine is and science is going to get it wrong some of the time. And but these things are also really hard to study. They're really hard to study and hard to design perfect studies because there's so many factors that play into it. And so we make our best guess with the information we have at the moment. We make recommendations, but a better study could come out to disprove it. And then we have to change our opinion in the future. That's why we're flip-flopping, because now there's a new study that's better that says the old study was wrong. It doesn't mean that we were dumb and then you can't trust us. It means that we have better information now, so we're just changing our mind. And that's scientists change their mind all the time because
yeah.
you have to be skeptical. I don't know. I don't know. I don't believe, I don't know what the answer is unless it's proven to me.
Yeah, no, that makes sense. I think a lot of them are not even necessarily pills, but it's kind of like vitamin combinations and extracts from different fruits or whatever.
Be very skeptical.
And I think yeah, you're saying be wary. Makes sense. Last kind of question before we get you out of here. Um, what are some, maybe, I don't know if you had common misconceptions or things that you would like to tell the general public of that maybe they don't know, or maybe things that you would like to clarify or clear up, or like what is some misconceptions that people think about the profession that you're like, no, 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 it's actually not that way at all, and it's this way instead.
I mean, the biggest thing that I want to talk about, and the reason I wrote the book was I call it like a love letter to neurosurgery, right? And it's because as much as we can complain about hospitals and insurance companies, the truth is the practice of neurosurgery is an incredible profession. It's a remarkable profession. The amount of things that we do, the weight of the responsibility, the training, the teaching that goes into it, the pursuit of excellence, all of that is what I really want to emphasize in the book. Most people latch on to, oh, you gave potassium chloride or something because it's kind of a fun story to tell, and like, it sounds scary, and it is, and there's a message there. But the take-home message isn't that some intern is going to be injecting potassium chloride into your IV the next time you go into the hospital. That is not the message. The message is really, that neurosurgeons in particular, that's what the book's about, but doctors in general, are people who have devoted their lives and sacrificed an enormous amount to take care of you. And they are going to do their very best to make sure that you have the best possible outcome. And that you should trust doctors. It doesn't mean you shouldn't get a second opinion, a third opinion. Absolutely, because we're not perfect, right? But I could be giving you the best available answer I have, but it might not be right. But I'm trying my best. It's not because I'm not trying my best and I didn't work my hardest to learn as much as I could and be the best neurosurgeon I could be. It's because I'm a human being and I'm not perfect. So you should get a second opinion, a third opinion, and then decide where you want to go with that. And someone else may do a better job or have a different opinion, and that's fine. But it's not that you can't trust us. It's that we're not perfect, but we're doing the best we can. And I think that's the message I would leave people with.
Makes sense. Tell the people you can get the book Gray Matters on Amazon and everywhere else you can get books, or tell the people where
Yeah,
they
if you
should go
like
to find it.
audiobooks, there's a great reader. It's not me. I got a professional to do it who has a better
Oh, you should have
nicer
done it.
voice than I do. I thought he'd do a better job. Um, Maybe that was a decision made out of fear, and I now regret it. No, I'm not sure I do. The guy who read it is a professional. He's really good, and I'm not a professional actor. I'm not a voice person. I don't know. So audiobook's great. Kindle is fine, obviously, and but the hardcover is something you hold in your hand. I love the feeling of a real book in your hand. Gray Matter is a biography of brain surgery. There's actually another book called Gray Matter, written by a neurosurgeon, and I think he's getting a lot of play in his book since people aren't sure which one is mine. But this one is Gray Matters, an autobiography of brain surgery, and it was really fun to write. It took me about a year to write it for whoever's interested.
Very nice. People go check that out. Links will be in the description, of course. Any last nickels before we get you out of here?
Last nickels, is that what you said? I've never heard
Yeah.
that expression.
I don't know. It's a phrase I picked up. Like last thoughts. I don't like saying last words because then it feels like I'm about something bad is about to happen.
No, it's a pleasure being here. Honestly, you asked great questions, and it was super fun just chatting with you. So I hope you enjoyed it as well.
I did definitely learned a lot. For those listening, like I said, links will be in the description as always. Thank you for listening, and we'll see you guys next time. Peace.
Bye bye.
Thanks for tuning in to the World XP podcast. If you want to watch another episode like this one, click there. If you want to subscribe, click there.